All right. So today we are going to start on the mid-gut. I'll start the lecture with the last few slides of the notes, GIT pain and anatomy related to GIT pain. Okay? And then I come back to the development of the mid-gut, and then going into the hepatobiliary system, portal circulation, and intestinal obstruction. Okay. So we can come to the right to the end of the lecture notes. Okay. So GIT pain. So as you know, gastrointestinal system being a visceral structure, it is associated with visceral pain, as well as there are a few other modalities of pain that can be associated with the GIT pathologies, right? And it is important to understand this in your clinical practice. However, I have to give this advice: don't think too much about it, right? If you think too much about the referred pain, visceral pain, somatic pain, you get confused. Okay, it is nice to understand the basics and then try to apply it in a clinical situation, rather than going into the count of this visceral pain, referred pain, somatic pain, viscerosomatic, visceral. There are many types of pains. Okay. So today I'm not going to do a lecture on pain, but to try to explain GIT pain using the anatomy. Okay, right. So GIT as a visceral organ, it causes visceral pain. What is visceral pain? It's by nature, visceral pain is a deep pain. That's the first thing to remember. It doesn't occur in the superficial structures, right? Working now? Right, so can you all hear? At the back? Yeah. So the GIT, or the visceral pain, is a deep-seated pain. And in relation to gastrointestinal system, this deep visceral pain usually occurs in the midline. Okay, usually, not always. It can occur in right side, left side, right, anywhere. Okay, usually it occurs in the midline, deep in the midline. And visceral pain can be associated with things like referred pain, which I'm going to explain later, and symptoms like nausea and vomiting, as well as associated reflex muscle spasm. Again, I will explain the mechanism. Okay, so those can be associated symptoms and signs of visceral pain. Right. In addition to visceral pain, gastrointestinal pathologies can be associated with somatic pain. Right? If gastrointestinal pathology affects a somatic structure, it can cause somatic pain. Okay, it can cause somatic pain. Now, what are the stimuli for visceral pain? Now, visceral organs are usually, we say it's pain insensitive, relatively pain insensitive, right? And there are no specific pain receptors in the visceral organs. Also, the density of sensory innervation is much less than the somatic organs like skin. Skin is densely innervated, right? Whereas visceral organs has a very poor innervation in terms of sensory innervation. Okay. Now these are the stimuli of visceral pain, common ones. Distension of a visceral organ, like if you talk about the gastrointestinal system, distension of the GI tract can cause painful sensations. Or ischemia is another one. Lack of blood supply and inflammation can cause. So those three are the common causes of GIT visceral pain: distension, ischemia, and inflammation. Cutting of now, if you cut a stomach, once you open the stomach, if you cut the stomach, it won't cause any pain. So if you can open the abdomen, and after that you can do a surgery on the gastrointestinal system without any analgesics, provided that if you can open the abdomen, okay, without causing pain. Cutting using a scalpel won't cause pain, right? So it's different. Other than these three, traction on the mesentery causes pain. Now this can demonstrate if someone undergoes surgery for hernia under local anesthesia. Right? Sometimes we do that surgery under local anesthesia. If it is an open surgery, when you pull the bubble loop in the hernia sac, that causes pain. So traction can cause pain. Right? The other one is this intense smooth muscle spasm. Right? Spasm of the smooth muscles. When there's increased intestinal motility, that again can cause pain, but the mechanism is commonly ischemia there again. Right? When there's intense muscle spasm, it causes a relative ischemia within the musculature of the GIT, and that can cause pain. Right? So these are the common stimuli, right, of visceral pain: distension, ischemia, inflammation, traction, and smooth muscle spasm, which is probably due to ischemia again. Is that clear? These are the stimuli. Okay. Okay, so this is a classic example I use to explain different types of pain. So at the moment we know GIT can cause visceral pain and somatic pain both. Okay, so let's go through this. So this is a patient, 16-year girl. It's a classic history of appendicitis, acute appendicitis. Okay, so he presents with nausea and vomiting, with on and off periumbilical abdominal pain. So initially, her pain was periumbilical, which is associated with nausea and vomiting. And then later, the periumbilical pain was shifted to the right iliac fossa, periumbilical region pain, and then it shifted to the right iliac fossa. And sometimes the pain radiates down to the groin and upper thigh. Not only there, initially here, going to the right iliac fossa later, and sometime later, this patient complains of pain going into the lower abdomen, groin region, as well as to the upper thigh as well. So on examination, there was right iliac fossa tenderness, guarding, and Soy's sign positive. I'll explain this, okay? Right. And in history also, it is mentioned she has been constipated for last 3 days, and she is also a sprinter, training for an upcoming national championship. Right? Interpret the findings. Okay, now. So when I explain this, you should be able to interpret those clinical findings in that scenario. All right, so here's the appendix, right? So that's the lumen of the appendix. The pink color area is the wall of the appendix, right? That's the parietal peritoneum overlying the appendix area on the right iliac fossa. Parietal peritoneum covering the abdominal wall there, okay? And behind the appendix, you have the psoas major muscle, right? I'll come back to this later in the lecture again. Psoas major muscle and a somatic nerve, genitofemoral nerve, right? Now these are relationships. So behind the appendix, you have the genitofemoral nerve and the psoas muscle somewhere there. You can draw it here. Psoas muscle here, right? Okay. And this is the spinal cord segment at T10 level and the brain. Okay. So the pathology is initially in acute appendicitis. It is in the wall of the appendix, the mucosa. So which is intramural. It is confined to the wall of the appendix. So we call intramural. Right. So when there's intramural pathology, it will stimulate the visceral nerve fibers and via these sensory nerves, the pain signals goes to the T10 segment, because the appendix is generally mainly innervated by the T10 spinal segment. Okay, so it goes to the dorsal horn of the T10, and from there the sensory pathways will transmit these pain signals into the brain. And now you will feel the visceral pain. Okay, the visceral pain, which is deep and usually towards the midline of the abdomen, since the appendix is developed from the mid-gut region and is innervated by T10, it will be in the central abdominal region, at the level of the umbilicus. I'm not talking about the umbilicus, it is at the level of the umbilicus, deep. Is that clear? Okay, not on the skin. Okay, so initially the pathology is in the intraneural area, and it causes visceral pain because it only stimulates the visceral structure. So it causes visceral pain, goes to the brain, so you will feel the pain at the periumbilical level. Okay, deep pain in the periumbilical level. Okay, so that's the visceral pain. Is that clear? So you can apply this to any organ, stomach or whatever, if there's transneural. Okay. So next, now this spinal segment T10 segment. Now please correct this. I think your diagram it says T5. Okay, please make it T10. Okay. So this spinal segment, dorsal horn, receives not only from the visceral organs but from the somatic organs like skin, and that innervation is dense. Lot of neurons comes from skin, from the T10 dermatome, and T10 dermatome is usually at the level of the umbilicus, right around. Okay, so this is skin now, and that also sends input into the dorsal horn, right? And brain usually used to get input from the skin, nociceptive input from skin and the somatic organs rather than the visceral organs. Okay, so because of that, sometimes brain misinterprets these signals and it thinks the pain is coming from the skin rather than from the appendix. And this is where you can get a referred pain on the somatic structure, on the skin. So therefore the referred pain is felt on the skin, basically. Right? Now, I'm not going to confuse you, but be aware there are different types of referred pains. Classically, we talk about referred pain due to a pathology in the visceral organ causing pain in a somatic organ. We call it a viscerosomatic referred pain. That's the classic one. And if you know that, that is enough. Okay? But there are other referred pains like visceral. Right? Pain, pathology in the rectum can cause pain in your uterus. Some example like that. So visceral. And there are somato-visceral and somatosomatic. There are like that. Right? Okay. Be aware of that. So that's the referred pain. Okay. And there are different theories for that. I'll briefly go through that in the next slide probably. Different mechanisms. So that's the referred pain. So that's a second type of pain. So GIT pathologies can cause visceral pain and referred pain. Okay. The third category is, it's a rare one, right? But it's good to know the mechanism. But it doesn't occur always. That is, sometimes these visceral pathologies can cause muscular spasm. That is, when these signals comes through the sensory neurons, it goes to the dorsal horn, and from dorsal horn, these interneurons in the same segments stimulate the motor neurons in the anterior horn in the same segments. So that can cause muscular spasm, segmental muscular spasm, right? Especially the back muscles. And when the muscles spasm for a longer time, it can cause pain. It can cause a back pain, right? That's not common. It can cause both, I think. Right, but here the pathology is in the appendix, so it's a visceral one, that's why I use that, okay? So the signals originate here, visceral. It can. So then it can become somatic type, okay? Right. So this neuron can stimulate these motor neurons and which undergo spasm. So muscular spasm can cause pain. It's another type of pain. Right? So it's a type of somatic pain actually because muscles. Right. But it is not common. It doesn't occur always. Right. The third one is a classic somatic pain and it is due to this. The pathology now become transmural. Initially it was restricted to the intramural side, mucosa. Now it is spreading, right? So inflammation spread, it becomes transmural inflammation and it goes to the periphery. And once it goes to the periphery, it causes inflammation of the visceral peritoneum, spread into the peritoneal cavity and the parietal peritoneum. So now this parietal peritoneum is red. So involvement of the parietal peritoneum due to transmural inflammation now stimulate the parietal peritoneal sensory fibers, which is a somatic organ, and it is densely innervated. It's a somatic pain, and now you can locate it. And that will occur at the site of pathology. So in relation to appendix located in the right iliac fossa. So now this inflammation which spills over the appendix, it goes to the parietal peritoneum in that area, so it causes right iliac fossa pain. So that girl initially had periumbilical but deep-seated pain, which is associated with nausea, which is visceral. And now, when the pathology becomes transmural, it shifts to the right iliac fossa. So that's a somatic pain, and it occurs in the abdominal wall. And the patient, you can ask the patient at that stage to pinpoint using one finger. They will tell that. Whereas that visceral pain, they will say something like that. They can't pinpoint it. Okay? Somatic pain, they will. Is that clear? Right. And the fourth type, or the fifth type of pain which can occur due to GIT pathology is neurogenic pain. If this transmural inflammation affects a nerve running by, right, running close by, so the nerve can get affected by the inflammation. Neuritis. And that can cause a somatic pain or neurogenic type of pain, and it is usually like an electric shock type of pain, right? In the area of distribution of the nerve. So in this case, there are few nerves which are around the appendix. I will show in the next slide. Commonly affected one is the genitofemoral nerve, and if that genitofemoral nerve supplies your groin area and upper thigh. Genitofemoral. Okay, so the patient can get pain in the groin as well as upper thigh. So that girl had that. So that means it becomes transmural. It has gone into the peritoneal cavity. It has affected the surrounding related structures. It's a neurogenic pain. So these are the ways that you can get pain due to GIT pathologies. It's not only visceral. There are somatic pains. There are referred pains. There are muscular spasms, and there are neurogenic pains. Okay? Right. Okay, so please go through that case again and try to explain. Okay? Right. Now, what is Sway's sign? So I have already explained. I'll come back to this. Yes, so let us finish this. So these are some relations of the appendix, right? And in the practical notes, I think there's a question on different positions of the appendix. Was there a question on that? Different positions? Yes, please go through that. I don't have time to go through that, okay? So there are different positions of the appendix, right? It can be, so one example is like it can be behind the cecum. It's called the retrocecal appendix, okay? Now, here's the cecum, and that's a different positions of the appendix. That's the psoas muscle. It is directly behind the cecum. And this yellow line indicates the genitofemoral nerve, which runs behind the cecum on the surface of the psoas muscle. So this is the genitofemoral nerve. It runs on the surface of the psoas behind the cecum. And this is another nerve, lateral femoral cutaneous nerve. It is rarely affected in appendicitis. And that's the iliac the vessels. Remember, the iliac vessels are crossed by the ureter. So ureter, it's not here, it's here, right there. So that's the ureter. It crosses the common iliac bifurcation. And that is also an important structure. Okay. Now, how can this be important in relation to the clinical signs and symptoms of appendicitis? Right. A ureter, so I'll go through this one, can be affected if the appendix is longer and projects into the pelvic cavity. We call this a pelvic appendix. Right? If the appendix is longer and is going right into the pelvic cavity, it can occur in some people. It can come to lie close to the ureter and it can overlie the ureter. So appendicitis in that patient can irritate the ureter. And irritation of the ureter usually causes again pain radiating from loin to groin. Okay? So a pain coming from loin to groin in a suspected appendicitis patient may indicate his appendix is a pelvic type of appendix, probably. Okay? It's clinically important. And then genitofemoral nerve I already described, so that's the direct posterior relation. So what type of appendix would cause irritation of the genitofemoral nerve? Yeah? Retrocecal. If it is behind the cecum, so all these structures are behind the cecum. So retrocecal appendicitis can irritate the psoas muscle as well as the genitofemoral nerve. Now, when the psoas muscle is irritated by inflammation, it gives rise to the physical sign called psoas sign. You can perform that in a suspected appendicitis patient. So what you do is psoas major muscle causes the flexion of the hip, right? So if you extend the muscle, you are stretching the muscle. If you extend the hip, you are stretching the psoas muscle. So if you try to extend the hip of an appendicitis patient with a retrocecal appendix, it can cause pain. That is called the psoas sign. So again, it's relationships of the anatomical relations of the appendix. Right. Another one is this. Now, just to overlap the pelvic bone, and that's the iliac crest. And somewhere here, okay, I don't know, I don't think you can see it. Can you see a red structure here? That's another muscle you will study next year. It's called obturator internus, right, inside the pelvic cavity. Yeah, that is the obturator internus muscle. Okay. So again, a pelvic appendix which goes into the pelvic cavity can irritate the obturator internus muscle and give rise to another sign called obturator sign. An obturator internus muscle usually laterally rotate the hip this way. To laterally rotate the hip. So in an acute appendicitis patient, you can elicit this sign by trying to laterally rotate the hip joint. Okay, if you stress the obturator internus muscle, it causes pain. Again, that may be an indication of a pelvic type of appendix in that patient. So all these signs can be used to diagnose or to prove a diagnosis of acute appendicitis. Right. So this is why you study all these different relations for physical signs. So we did that, ureter. So the parietal peritoneum involvement I mentioned. So when a parietal peritoneum is affected by inflammation, it causes a condition called, leads to a condition called peritonism. Right? Inflammation of the peritoneum is called peritonitis, and peritonitis leads to a condition called peritonism. The signs of peritonism are signs of irritation of the peritoneum, and they are guarding, rigidity, and rebound tenderness. So what are the mechanisms of guarding, rigidity, and rebound tenderness? Guarding means when you try to press the abdominal wall, palpate the abdominal wall in a patient with peritonitis, when you push in, that you are stretching the peritoneum. So that will irritate the peritoneum, right? And when you do that, pain signals goes into the spinal cord, somatic pain signals from the irritated peritoneum, and then via interneurons, these pain signals can stimulate the nerves supplying the body wall muscles, and that those muscles will undergo spasm. So when you try to feel, palpate the abdomen, push it, the patient will contract the abdominal musculature. That is called guarding, and that is the mechanism of that. Is that clear? Guarding. Rigidity is abdomen in generally rigid in this patient. Not only, even when you are not palpating, it is rigid. Muscles are undergo spasm. So that indicates more severe degree of peritonitis probably, right? Even you don't have to stimulate by palpating, right? The inflammation itself causes reflex smooth muscle spasm of the segmental abdominal wall muscles. That is called rigidity. So guarding and rigidity indicate peritonism, and it is peritonism is commonly due to peritonitis. Okay. Right. Then rebound tenderness, again another sign of peritonism, and here the pain is elicited by you palpate the abdomen, to do a deep palpation, and you take your hand off suddenly, and that sudden release causes sudden provocation of the inflamed peritoneum and causes pain. Okay, so that is for the rebound tenderness. So these three, guarding, rigidity and rebound tenderness, indicates peritonitis. Okay, so in a patient with suspected acute appendicitis, presence of guarding, rigidity and rebound tenderness indicates rupture, usually ruptured appendix or transmural appendix. So these signs can be initially localized to right iliac fossa, and once the peritonitis becomes generalized, it can go all over the abdomen. Right, so those are some important aspects of in relation to appendicitis. Now, what is McBurney's point? And these things might be asked by the surgeons in your clinical rotations. By definition, the McBurney's point is that's a maximum point of tenderness in acute appendicitis. That is usually located roughly between, so if you draw a line from the umbilicus to the anterior superior iliac spine, it is at the junction of the lateral 1/3. Right? So if you put a finger there and press it, because acute tenderness there. Okay, so it's called the McBurney's point or the McBurney's sign. Okay, I'm not going to details. So these are theories of different theories of referred pain. Right? Very quickly, I have included three theories: axon convergence theory, spinal convergence theory, and thalamic convergence theory. Out of these three theories, most of the people accept this spinal convergence theory, right? So in axon convergence theory, the theory is some of the neurons have axons or dendrites going into both skin and viscera. So same neuron has connection from the skin and viscera. Right? And then, so the convergence occurs at the level of axons. So they use that hypothesis to explain. And there are some evidences for that. But mostly it is this convergence of signals occur in the spinal cord. Right? And again, there are two mechanisms. The neurons from the signals from the skin and viscera converge in the spinal cord. However, most of these inputs are coming from the skin. Therefore, brain tries to interpret that is coming from the skin. That is one. The second one is both these again converge at the dorsal horn, and they are very close by in the dorsal horn, these neuron populations. And when a visceral organ is affected, the signals coming through the visceral neurons reach this dorsal horn, and they are spilling over of signals spills over into the surrounding area, these signals, right? And they stimulate the neurons in the skin, coming from the skin. And now you feel the pain coming from the skin. Okay, so that's another one. So that both these are well accepted, and that's called the spinal convergence. And the last one is, some people talk about the thalamic convergence. It's also the convergence not occurs in the spinal cord but at a higher level. Okay, right. The last slide into GIT pain is these two pain lines. Now generally, I mentioned in my first lecture, GIT pain is mainly mediated by the sympathetic nervous system. And that is why we talked about this referred pain, and in that way it is easy to talk about the referred pain because sympathetic has a segmental innervation loss. Okay, so most of the GIT is, this whole area is innervated by the sympathetic nervous system. But the two ends, the top end and the bottom end, is by the parasympathetic nervous system. For example, most of the esophagus, the middle and upper part, is by the vagus nerve, and down here, the sigmoid colon and the anus and anal canal and the rectum, they are innervated by the sacral splanchnic nerves, again parasympathetic. So these two ends have a dominant parasympathetic mediated pain innervation, whereas most of the GIT has a sympathetic mediated pain, right? All right, so we'll get back to the development. Is that clear, the GIT pain, or did I confuse you more? Okay, right. Okay, so this patient, the female, 18 years, presented with severe diffuse abdominal pain. The diffuse abdominal pain, severe. Initially, because before this pain, it was a periumbilical pain again, right? It was in the region of the periumbilical region. And she gives a history of NSAID use. On examination, there was tachycardia, and his running temperature. Abdomen diffusely tender, tender abdomen, and there was rebound tenderness, guarding and rigidity. What does that indicate? There's diffuse peritonitis now everywhere. Okay, so started with some periumbilical. We can assume probably a problem in the midgut derived structure. Probably, maybe or may not be, right? So we can assume in your differential diagnosis initially. Probably a pathology in the midgut region. Okay? Right. So what do these findings indicate? Most likely a peritonitis due to a midgut derived pathology. So this is the X-ray. You can see. I will quickly go through. Gas under diaphragm. Okay? Both sides. So that's the gastric air bubble. This is gas under the diaphragm on left, and here the right. So which indicates free gas within the peritoneal cavity, which usually indicates ruptured viscous. Okay, so we have a condition here, peritonitis, free gas, probably a midgut pathology. Emergency laparotomy was done, free fluid was present in the intestinal loop, so there's peritonitis. Okay, no perforation was found in the stomach and duodenum. So patient has a history of NSAID. And you would automatically think this patient has a peptic ulcer, ruptured peptic ulcer. That is my first differential diagnosis. Okay? NSAID use, ruptured peptic ulcer causing gas under diaphragm and diffuse peritonitis. Okay? However, there's no rupture, no ulcers in the duodenum or stomach. These are the common regions you get peptic ulcers. Further exploration revealed a leak in diverticulum arising from the distal ileum. So this is what they found. In the ileum region, you get a leaking ulcer or diverticulum. So what is the diagnosis? Yeah? You studied this your first semester. Yeah, so that is the structure usually associated with the ileum, the Meckel's diverticulum, persistent of the part of the vitalointestinal duct. So this may be that diverticulum. So now there's a leaking diverticulum with inflammation there. Right? So if you find a diverticulum like that in the surgery, it is usually the Meckel's diverticulum, especially in a young person. Okay? So this patient has caused diverticulitis and rupture. Okay? And pathology report. So this was resected and sutured. So resected part, the histology indicate gastric type of mucosa with acute inflammatory changes and ulceration. Is it common to get gastric type of mucosa in an intestinal loop? Is it common? No. However, this is not a normal structure. Now this is a derivative of a primitive embryonic structure. Because the vitalointestinal duct, they can undergo any transformation because they are more pluripotent cells. Okay? They can undergo, differentiate into any type cells, and they commonly, not uncommonly, they differentiate into gastric type of mucosa. Okay, so in Meckel's diverticulum, sometimes you get gastric type of mucosa, therefore they can respond to NSAIDs. Okay, so when you take NSAIDs, not only your stomach mucosa can get, wherever you get a gastric type of mucosa, that can be affected. Okay, so this patient, the stomach is not affected, however, this part of the GIT is affected because it has got a gastric type of mucosa and it causes ulceration and rupture. And it is derived from the midgut region, that is why he gets the deep pain at the level of the umbilicus initially. Once it is ruptured, content is gone out, cause peritonitis, diffuse abdominal pain, diffuse tenderness, that is peritonitis. Okay? Right. So we'll quickly go through the development of the midgut. I want to finish this in 10 minutes. Okay. So the midgut development usually, and most of the midgut development occurs between week 11 and 15, most of it. Okay. You can see here, so that's the stomach, that's the midgut loop, and that's the hindgut. Okay. And you can see the midgut loop is connected to the amniotic cavity via the vitalointestinal duct into the yolk sac. Okay, so that patient has a persistent small part here up to there. This usually disappears, right? By about 10-11 weeks, this is disappeared. But in the previous patient, it was persistent. Okay, right. And yeah, so you have the superior mesenteric artery. Now that's the dorsal mesentery. You can see that's a ventral mesentery. Most of the ventral mesentery disappeared in this area. It is only restricted to the foregut region. Okay, so that is, what is this? The less omentum. Okay, so in the dorsal mesentery, the midgut loop here, you get within the dorsal mesentery, what is the artery you get? Superior mesenteric. So superior mesenteric artery will come like that, and it gives a branch to the vitaline branch as well, going this way. Okay. Now, do I have to go through this? I think I would like to skip this. I have done it. I think we have done this as well last semester. So this is a vitalointestinal duct can persist in different ways, like a diverticulum, a small diverticulum with a fibrous band connected to the umbilicus, or only a fibrous band. There are different types. Okay. Now this is the commonest variety, like in that patient, Meckel's diverticulum. This is not that common, but this kind of pathology, this one and that one, can cause problems to the surrounding bowel loops. It can cause, twisting of bowel around and causes intestinal obstruction. Okay, like that. Answer for this, I'm sure you know that now. Right, okay. So the midgut loop, which is here, I have used two colors. The yellow one is the proximal limb, and this red part is the distal limb of the midgut loop. So that's foregut, midgut, and hindgut. That is your superior mesenteric artery. Okay, and remember last week we did the rotation of the foregut, mainly the stomach, which undergoes 90 degrees clockwise rotation. In contrast, the midgut loop undergoes, oh, you have to correct this, 270 degrees counterclockwise rotation of midgut. Please correct this. Okay, 270 degrees counterclockwise rotation of the midgut. Okay, right. So the midgut undergoes 270 degrees counterclockwise rotation. I'll explain it. Now this yellow part gives rise to the proximal part of the midgut, which is from the second part of the duodenum to the cecum. And here's your cecum, and appendix develops here. Cecum, ascending colon, transverse colon is developed from this part of the midgut loop. Right. Now this is how it rotates. After about 6 weeks, the abdominal cavity, there's not enough space within the abdominal cavity. The reason for that is the massive or the development of the liver. It occupies most of the abdominal cavity, therefore there's no space for the developing bowel loops. So they are pushed outside into the amniotic cavity through the umbilical ring. So most of the GIT tract, the initial development occurs within the amniotic cavity covered by the periparietal peritoneum. And this is called a physiological herniation. So that occurs in every fetus. Physiological herniation. Midgut loop goes out into the abdominal cavity, into the amniotic cavity, and it is covered by the parietal peritoneum. It goes out into the amniotic cavity via a ring-like opening in the umbilicus, and that fuses fairly late. Okay. So this loop now goes out because there's no space. So initially, when it goes out, it rotates. Now initially the position of now that is your proximal limb, this is the distal limb. This is the proximal limb and the distal limb. And this is the axis of rotation, which is your superior mesenteric artery. So this rotation occurs on the axis of the superior mesenteric artery. Counterclockwise rotation. So it rotates this way. So initially it undergoes, now that's the initial position, it undergoes 90 degrees rotation. See, now the distal end is here, proximal end is there. Right? So initially your cecum area somewhere there, the duodenal flexure is there, it undergoes 90 degrees rotation, it comes here, 90 degrees. Okay? And if it goes to further 90 degrees, your cecum somewhere there. So now 180. Then next 90 comes 270. So your cecum is close to the liver now. Right? So future cecal area started here, 90, 180, 270, close to the liver. So at the end of midgut rotation, the cecal area comes to there. So that's your liver somewhere here. So it's originally it was there, 90 degrees, 180 degrees, and 270 degrees. So future cecum and the appendix comes to lie close to the liver, just underneath the liver. Okay? Is that clear? So there's twisting of the midgut loop around the superior mesenteric artery axis. Now when this happens, you can see, now that is a twisted loop that loop of bowel comes to lie over the future duodenum region. I have a tube, but I don't think I can explain it. You can see, I'll try to. Okay. Right, so just assume that is the midgut loop. Okay? So that's the proximal part, so, okay, the other way around, sorry. Right, so that's the duodenum, right? First part, second part, first part, second part, third part. So that's the future jejunum. So that's all jejunum, small intestine. And let's assume this area is your cecal region, future, right? And then future ascending colon, transverse colon, midgut loop, okay? So this will rotate like this. So now this is the position, now it's 90 degrees, right? 180 degrees and 270 degrees now. Okay? So when it's 270 degrees, it's here. Your liver is there, subhepatic. And you can see this part, now that's the cecum, and next to that you get the ascending colon and the transverse colon here. And that part of the midgut is crossing over the duodenum. Can you see? And that is why in our adult abdomen, the transverse colon goes over the duodenum. And not only that, when it occurs, it will push this duodenal loop, which initially it has had a mesentery, dorsal mesentery. Now it is pushed back onto the abdominal wall and it loses its mesentery, duodenum. So most of the duodenum become retroperitoneal. Okay? So that is how it happens. So as a result of midgut rotation, the precision of the GIT changes. Initially everything was in the midline, and after that it changes. So it causes change in position of the midgut GIT structures, and also some of the organs become retroperitoneal. Okay? So not only the duodenum which becomes retroperitoneal, after a while the ascending colon and the descending colon also loses its peritoneum. It is compressed onto the posterior abdominal wall and loses its peritoneum. Okay. Now the next stage, once after the rotation is complete, now the bowel loop has returned back into the abdominal cavity. So by the time it reaches, it has undergone 270 degrees. Okay. Now this is around about 11 weeks. Okay. And now there's enough space. Abdominal wall, abdominal cavity has grown, so there's enough space. All the bowel loops comes back into the abdominal wall. By about 10-11 weeks, everything is inside again. Okay. And here, as I said, the cecum is subhepatic. The next stage is the cecum has to go down, so it can't lie there. It has to, come back to the right iliac fossa. So it is called the cecal descent. So the next process is, so midgut rotation is followed by cecal descent, and the cecum comes to the future, the right iliac fossa region. So midgut rotation is followed by the cecal descent. Now what would happen if this cecum does not descend? Now we can see initially now this is the duodenojejunal junction, start of that's the proximal part of the midgut. And this point was initially here in the midline. So it rotates 90, 180, 270. Now because of that, you can see now the midgut loop is this. Initially it was attached from there to here. It has a wider attachment. Now at this position, subhepatic position, the distal end X and the proximal end Y are very close together. Even in the adult cadaver, you get the duodenojejunal flexure somewhere here. And if your cecum is there, So you have the attachment of the two bowel loops. This proximal end and distal end, the two positions are there. So that is your attachment of the mesentery, dorsal mesentery. So you have the bowel loop like that, and everything is attached to that narrow area. Right? So if there's a subhepatic cecum, without the cecal descent, the midgut will have a very narrow based mesentery. From there to there only. Initially it goes from there to there. Because of the rotation it comes like here. It has a very narrow base. What is the risk? It can twist. Because it has a very narrow base. So the bowel loops can twist easily. Okay? Now, that is why the cecal descent is important. So it comes like that and then it will go down. So your mesenteric attachment, so attachment of the mesentery of the small intestine goes there, the distal end. So therefore, in adults, in the cadavers, you will see attachment of the mesentery start from there and goes to the right islet across the abdomen like that. You can see it tomorrow. Okay? If it stops there, it causes a problem because it can twist. Okay? Is that clear? Yeah, so this is what I explained. So at the end of the midgut rotation and cecal descent, all the intestinal loops occupies their future positions. Right. Now, at the end of the midgut rotation, about after 11-12 weeks, certain of parts of GIT is completely covered by peritoneum. We call them intraperitoneal. So intraperitoneal structures, for example, these colored ones, stomach, your transverse colon, your small intestine, cecum and the appendix, and then the sigmoid colon. They will all retain their mesenteries. They retain their mesentery means they are completely covered by the peritoneum. Therefore, they will have a mesentery. They are called intraperitoneal organs. Whereas some of the organs become retroperitoneal or partially retroperitoneal. These are the uncolored ones, like the duodenum. It is compressed onto the posterior abdominal wall, loses its mesentery, ascending colon, descending colon. Right? They all lose their mesenteries and they become like that. So their mesentery is absorbed. So this part is absorbed, right? And they become retroperitoneal. But in the cadavers we will see, no, not all the ascending and descending colons are like that. Sometimes they might be, they can have a small mesentery. Right? Those are variations during the development. But classically, these two structures has to be in contact with the posterior abdominal wall, retroperitoneal. Right. Okay. Then the last one is infra or subperitoneal, means they are below the peritoneal. The sub or infraperitoneal structures are your pelvic organs. Right? So you have the anterior abdominal wall peritoneum, then goes down and become posterior abdominal peritoneum. So anything below that is infra or subperitoneal. Your uterus, ovaries, the fallopian tubes, your bladder, they are below the peritoneum. They are not retroperitoneal, they are below. Retro is behind. Below. Okay? Most of your pelvic organs are subperitoneal. Okay. Now this diagram shows the different peritoneal reflections. Now let's see, you can identify them. Okay. Right. So this is liver, stomach, and the spleen. What is this? Quickly, before your break. The spleno. That's the splenorenal ligament, right? Origin is dorsal mesentery. This one, gastro. That's a gastrosplenic ligament. What is this? Yes? Yeah? The gastrohepatic ligament, yes, from the stomach to liver, gastrohepatic, as is a part of your lesser omentum, right? So if you are asked, identify precisely in relation to stomach, that is called gastrohepatic. And there's a lower part of the lesser omentum we can call hepatoduodenal ligament. Okay, so hepatoduodenal plus gastrohepatic forms the lesser omentum, right? Then, what is this? That's your stomach. What is that? Anyone? That's a greater omentum. Now you can see greater omentum is formed by double fold of peritoneum coming out from the greater curvature of the stomach. Okay, so that's a greater omentum. And what is this? That's a transverse mesocolon. It is attached to the posterior abdominal wall. We can see it runs across the duodenum, and you have the pancreas behind that as well, which is again retroperitoneal. So it runs on the surface of the pancreas. So the transverse mesocolon is attached across the pancreas into the posterior abdominal wall. That's a transverse mesocolon. And these two are retroperitoneal. What is this? So that's a duodenum, first part, second part, third part. That's a duodenojejunal junction. That is where your mesentery starts, mesentery of the small intestine. Okay, so see, it is attached in the midline, proximally, and the distal end is in the right iliac fossa because of the cecal descent. So it has a wider attachment. If the cecum does not descend, this attachment will be there. Okay, right. So that's the mesentery, it runs across. What is this? This is the mesentery of that's a descending colon. Next part is sigmoid colon, because sigmoid colon has a mesentery. So that is there. So it has a V, inverted V shape of mesentery like that. Okay, and it is relatively narrow, inverted V shape, and the V shape further narrows the base of the sigmoid mesocolon attachment. In fact, sigmoid colon is one of the commonest, one of the most commonly affected part undergoes twisting or volvulus because it has a narrow base. Right. Okay. Well, the last question in this diagram is this: what is this space? Yeah, that's a lesser sac. Okay, rest of the area is greater sac. I think you don't have this slide, but try to identify these structures. Okay, now that's a sagittal section of the peritoneal cavity to show the reflections. So this is the peritoneum covering the liver. So what is that? That's a label, this omentum, stomach, and that's, you can see the greater omentum. So that is the lesser curvature of the stomach. This is the greater curvature of the stomach. So the lesser curvature is related to the lesser omentum, and the greater curvature, you can see the double fold of peritoneum runs down and folds back, and then comes and attached to the, or continues with the peritoneum covering the transverse colon. So that is how the greater omentum is created. So there's a double fold comes like that, goes down and comes back and attached to the, or continuous with the peritoneum covering of the transverse colon. So therefore you can see the greater omentum has 1, 2, 3, 4 layers of peritoneum originally. Okay? Right. And what is this then? Yeah? Sorry? If this is the transverse mesocolon, what is this? Transverse colon? Transverse mesocolon. Okay? You can see transverse mesocolon is attached close to the pancreas. That's the pancreas. Okay? So that's a small intestine, and that's the mesentery of the small intestine. Okay? And see the extent of the lesser sac. So the lesser sac is behind the stomach. So that is your lesser sac. originally you can see the lesser sac actually continues into the great omentum. But in most cadavers, usually these layers are fused. So you will see, you will not see this extension. You might see this extension of the lesser sac up to here. Right. Okay, one last question before the break. So that is, I said, great omentum. And this is transverse mesocolon. In the exam, if I pin this, only this area, what is it? And usually this is attached onto the surface of the transverse colon in the cadaver. Yes? Gastrocolic ligament. So you can see the gastrocolic ligament is part of your great omentum, which is attached from the greater curvature of the stomach onto the surface of the transverse colon. Okay? So you have, and if you're looking from anteriorly, the structure which connects the stomach to the transverse colon is the gastrocolic ligament, which is part of your great omentum. But if you look from behind, that is your transverse mesocolon. So depending on the view, there are two structures. Okay? So behind you get the transverse mesocolon, in front you get the gastrocolic ligament. Right? All right. Okay. Take a break now.
Couple of questions. You said between week 11 and 15, but is it 5 and 11?
Sorry, 5 and 11. Did I say 11 and 15?
Yeah. Okay. So that's all right. That's good.
Didn't have my breakfast.
No, me either. I'm suffering.
Again, I don't think I can finish the lecture. Am I going too slow?
No. No. I missed these two.
Yep. So that is something, that's a spleen.
Yep.
So that's the stomach, so gastrosplenic ligament.
Yeah, gastrosplenic.
You can see the, yeah.
And this is the lesser sac here, isn't it? I got that right?
Yeah.
And that one.
So that's the spleen to the posterior abdominal wall. You get the kidney development there. What is it?
Splenorenal?
Yes.
Ligament or?
Yeah. They're not true ligaments, they're just peritoneal folds.
Kind of attachments, aren't they? You go, Igor.
Will that be a greater omentum right here?
Yeah.
And it will be fusing onto the stomach, right? The greater omentum.
I mean, here it is attached to the greater curvature, but it's a connection to the gastrosplenic ligament.
Okay, so if I'll say do this, it will be via connection to the gastrosplenic ligament.
Alright, that's something else. You use that term, perineum? Perineum? Is that
Peritonicium.
Ah, that makes sense. There's one other question I had. I might have to come back if I can't find it. Sorry, Kareem, if you've got a question, go ahead, huh?
One of the last question was about how I go out in the hernias. I can't really picture it. Like, where is it?
Whenever there's organ become, retroperitoneal organ become peritoneal, right? So it causes folding of the peritoneum, right? So you have a tube like that, which is covered, retroperitoneal, and now suddenly become peritoneal. So there's folding of the peritoneum. Those regions you can get recess formation. And one example is at the duodenojejunal flexion. As an acute angle as well as duodenum, which is retroperitoneum, becomes jejunum, which is intraperitoneum. So that is an area where I get paraduodenal recesses. Okay? There are superior, lateral, and inferior recesses. And similarly, you can get recesses in relation to cecum and the distal ileum. It's something nice to know. Right? It's not a major thing. It's good somebody who's doing surgery. I don't usually, unless probably in MCQ.
Maybe I'll ask Shiva's tomorrow to show me that.
Look at some cadavers you can. It is easy in the life, it is flexible and you can stretch it. Otherwise,
Alright.
Okay. Okay. Okay, the next scenario is, there are two scenarios. Now these are some two ultrasound photographs taken from T2 women in their 16th week of pregnancy. So it's important, 16 weeks. Okay, this is what you see. So you can see that's the baby inside the uterine cavity. You can see a mass coming out from the abdomen. Right, so this is a postnatal photograph of the same baby. Okay, what do you think is this? Yeah? Omphalocele. So omphalocele is, now remember, there was midgut herniation. Midgut develops within the amniotic cavity covered by parietal peritoneum. But it usually disappeared by about 11 weeks. But this is now 16 weeks, it is persistent. Right? So when you do a 16-week ultrasound scan, your pregnancy, you should not see the physiological herniation. If you see that, the diagnosis is, it's called omphalocele. Omphalocele is, it contains herniated midgut structures, usually midgut structures covered by the peritoneum. So when the children, after they're born, this is how they appear. You can see inside the midgut loop, and this is the peritoneum, and this is the attachment of the umbilical cord. So that's called omphalocele. So it's another woman who is again 16 weeks pregnancy. What do you see here? You can see free. The bowel loops are not covered by peritoneum. You get free bowel loops within the amniotic cavity. So there's no peritoneal covering. That means there's a defect in the development of the anterior abdominal wall. Right? So that usually occurs with the flexion. Right? During flexion, the ectoderm, mesoderm, they all fuse. So defective fusion of this during flexion can cause gross abdominal wall defect. So the abdominal, this content is now floating inside. Right? And the things comes out. Okay, the intestinal loops. Okay, so in this condition it is not covered by the peritoneum. So these, it's again, you can only diagnose after 11 weeks of ultrasound scan. Okay. The next one, this baby was brought to the hospital following repeated episodes of vomiting. The vomiters was bright greenish yellow. So it's green color vomiters. Now last week I gave a case which I didn't have time to discuss. That baby had non-bilious vomiting. right? So this vomitus was bright greenish yellows, which indicate green is usually due to bile. Okay, bile. So this baby is vomiting bile. Last week's case, he was not vomiting bile. What was the diagnosis of the last one? Last week's case? Anyone who went through that case? Don't remember even? There was a case in the lecture note which I didn't have time to go through. Huh? Now, the baby presented with projectile vomiting. Just after feeding, the baby vomits, and that's explosive vomiting. Right? That's a pyloric stenosis, congenital pyloric stenosis. Okay? So, there's an obstruction in the pylorus. That's a classic presentation. Just after feeding, they vomit, and that's called the projectile vomiting. Okay? And the color of the vomiters is, they're not green, non-bilious. It's called non-bilious vomiting because the obstruction is more proximal. Now in this baby it is different. Now this baby presents with vomiting green colors, yellow greenish vomiters. And there was the patient was dehydrated, probably due to vomiting. And there was upper abdominal distension, and there's increased bowel sounds. What does bright green vomiters indicate? It usually indicates vomiting, biliary content. Okay? What condition would cause bright green vomiters? If it is, what condition would cause biliary, vomiting of biliary substances? If the obstruction is beyond the second part of the duodenum, where the bile duct drains in. If it is more proximal, there's nothing coming out, it is blocked. If the obstruction is just beyond that, not in the rectum, it's close to the second part of the duodenum. Just beyond that, there will be a build-up of the biliary fluid in the duodenum and the stomach, and then they vomit out. So bilious vomiting indicates obstruction distal to the second part of the duodenum. So what condition need to be thought of in this patient? So there can be many conditions which cause obstruction beyond the duodenum. But in this child, what would you think of? At least what group of disorders? It can be a congenital abnormality. So this is newborn, so it's very commonly it's a congenital one like atresia. Right? Atresia of any intestine, or we can say atresia of probably the duodenum. Duodenum is atretic, obstructed, not developed. There's obstruction beyond the second part. It may be that. So any congenital obstruction of the obstruction beyond the D2, close to D2. Okay, can cause that. So an upper GI barium study was done. This is how it appears. You can see this is the stomach. You can see it is distended. Sorry, that's the stomach and that's the duodenum. Okay, so you can see that it's grossly distended. And there's a small amount of barium passing into the distal part of the gut. And now it can appear in probably in the jejunal loop as well. Right? Now this kind of appearance is called the corkscrew appearance. Right? The tiny part there here, you can see that is the obstruction is. Very small, narrow. Right? And then everything again accumulated and gives rise to this appearance. So it's called the corkscrew appearance. And this is what was found. During surgery, it was found that the cecum was located just below the pylorus. Cecum, usually located here. Now in this baby, it was located just below the pylorus. Very close, up there. What was the problem? Cecum has not descended. Right? And the small intestine was rotated along the axis of small intestine, the superior mesenteric artery, obstructing the origin of the jejunum. So cecum has not descended, so there's a problem of rotation of the midgut, malrotation of the midgut, and cecal non-descent. And there was because of that, there's a very narrow base of mesentery, which causes twisting of the small intestine around the superior mesenteric artery. And it obstructs the duodenojejunal junction. So there's obstruction. Okay, so cause for this baby therefore is a malrotation of the midgut and non-descent causing narrow mesentery leading to intestinal obstruction. So this is what happens. The cecum is here, duodenojejunal flexion is there, it has a very narrow base, the bowel twists around, leading to, it's called the midgut volvulus. Volvulus is twisting of the bowel. Okay. Right. Another X-ray feature associated with similar condition is called the double bubble sign. Double bubble means when there's obstruction to the, in this region, duodenal region, it causes accumulation of the swallowed gas proximally within the stomach. And there are two bubbles appear. One is within the stomach, the other one is just beyond the pyloric sphincter in the first part of the duodenum or duodenal cap, and this is separated by the pyloric sphincter. So you have two bubbles and they are grossly distended, and it usually indicates a duodenal obstruction, and it usually occurs with duodenal atresia or intestinal atresia. It can occur with this as well, but uncommon, because this kind of situation might allow gas to pass through. Okay, but it can occur. So double bubble sign, it indicates duodenal obstruction, and you must know why there are two bubbles. Okay. Again, this slide I'm not going to do, self-study, and you need to know, just like what we did with the appendix and its relations, it is very important clinically to understand the relations of the duodenum, right? So the first part, second part, and third part. Okay. Now, just few points.
When you said that right before it was rotating on the brain of the superior carotid artery, is that with the artery at the same time? Or?
It can. So in volvulus, first consequence of any volvulus is it obstructs the lumen of the GIT, which causes intestinal obstruction, and if it goes for a while, it obstructs the venous drainage, it causes moedema, and then it occludes the artery, it causes necrosis. So finally they can cause intestinal ischemia and necrosis and death. Okay. So any volvulus, then the end result, if you don't intervene, is intestinal necrosis due to ischemia. Right. Okay. Yeah. So coming back to the duodenum, so it has three parts: first part, second part, third part, and another small fourth part. Second and third part are the retroperitoneal. Second and third part, that's the middle part. And the two ends, first part and the fourth part, they are in between. Can be completely covered by peritoneum or partially covered by peritoneum. Because stomach is fully covered by peritoneum, so this is a transition point. And jejunum is fully covered by the peritoneum, so the fourth part is a transition point. Okay, so these two, first part and the fourth part, can be slightly mobile, whereas second and third part are fixed. They are not mobile. They are retroperitoneal purely. Right. So please study the other relations, like the pancreatic head. So you should be able to work out what would happen if there's a pancreatic head pathology. Where would it, if it's a malignancy, where would it spread? What structures can be affected? And what are the physical signs? Okay, right. One last point, this artery, the gastroduodenal artery. It's a branch of the common hepatic, and this artery runs just posterior to the first part of the duodenum. And first part of the duodenum is very vulnerable to peptic ulcers because of the acid coming from the stomach. So posterior wall ulcers of the first part of the duodenum can affect the gastroduodenal artery or its branches, can erode into that. So that's an important relationship. Okay. Rest of the relations, please study. Okay. I'll skip that as well. This is definitely something you can study. Okay. coming to the intestinal obstruction. So that child, in this case, had intestinal obstruction due to jejunal obstruction following midgut volvulus. So let's talk about pathophysiology or pathoanatomy of intestinal obstruction. What is intestinal obstruction? By definition, it is arrest or significant obstruction to the passage of content. So what is now usually whatever which is inside the GIT is propelled forwards by the intestinal motility. If it doesn't occur, that is intestinal obstruction. Okay. And these patients usually present with colicky abdominal pain. Colicky abdominal pain is the pain which comes and goes like this. Right? And these colics occur when the intestine contracts rapidly to overcome that obstruction. So when there's an obstruction, if the intestine is still functional, it tries to overcome that obstruction. So it contracts rapidly, and that causes ischemia, and ischemia causes pain. Okay? Right. So colicky abdominal pain may suggest an intestinal obstruction. But there are other signs. They can have vomiting. If the obstruction is more proximal, these patients will develop vomiting very early, like duodenal obstruction, jejunal obstruction, pyloric obstruction. Okay? Because there's content accumulate here, and that causes vomiting. Or so depending on the nature of the vomiters, you can diagnose. It can help you diagnose the location. So non-bilious vomiting usually indicates more proximal, like pyloric obstruction. Bilious vomiting is distal to the second part of the duodenum. Fecal vomiting can occur. It's very rare, but it can happen if there's very distal obstruction in the colon. Okay. Right. The other signs, so vomiting is a sign, colicky abdominal pain. The third sign, classic signs of intestinal obstruction, is constipation. Right, because the intestinal obstruction, there's nothing passing through. So the patient is constipated, and they don't pass flatus, no air passing through the anal canal. So they don't pass. So you can ask them in the history. Either you are constipated, did you pass any gas or not? Yes?
So with the fecal vomiting, like, because it's obviously a long way for it to travel, is that just reverse peristalsis, putting it all out into the exit?
Exactly. So when there's obstruction, it tries to overcome, and also it can affect the whole peristaltic process, can cause reverse peristalsis as well. Okay, can happen. In my short clinical career, I have seen 2 patients. So you will see. Right. So what are the causes of intestinal obstruction? Right. Broadly, intestinal obstruction can be due to 2 broad causes. One is, then there's a mechanical obstruction. So the obstruction is mechanical. There's nothing wrong in the motility process. So these are the people who can get colicky abdominal pain. And this is a common variety. Mechanical obstruction, and we call it dynamic because the peristalsis is still there. Right? And to overcome the obstruction, there's increased peristalsis. The second one is the peristaltic mechanism is affected. The adynamic. There's no peristalsis. So if there's no peristalsis, there's no passage of food. So it is obstructed. And this is not very common. It can happen congenitally. An example is Hirschsprung's disease, which we talk about it probably next week. And in these people, there's an aganglionic segment. The enteric nervous system is not developed in a small segment of bowel. So that part of the bowel is not transmitting any food. So there's intestinal obstruction. Okay? Achalasia cardia is a similar one. Right? Then the secondary causes of paralysis of the intestine is called the paralytic bowel or paralytic ileus. And it may be a secondary cause, like it can be a metabolic disease, it can be a vascular disease or something causing a secondary, so ischemic electrolyte problems, they can cause paralysis of the bowel, paralysis of the intestinal musculature. So there's no peristalsis. So that group is called adynamic obstruction. Is that clear? Dynamic versus adynamic obstruction. So both conditions. Yes. Peristalsis presence, no peristalsis. Okay. So what are the common causes of dynamic or mechanical causes of obstruction? Now these are the ones. Obstructed hernia. So loop of bowel comes out through the abdominal wall and it is obstructed. So that's an obstruction. Obstructed hernia is one of the commonest causes of intestinal obstruction. So this is why if you go to the hernia, you have to get it operated. This is a complication of a hernia. It can get obstructed. Okay. Another one is volvulus that we talked. It's twisting of the bowel. You can see the lumen is obstructed mechanically. And the third one is a condition called intussusception. That is telescoping of bowel. Right? So due to a strong peristaltic wave can goes like that and goes into another bowel loop. Telescoping of the bowel. Okay, and these are usually associated with tumors. Right? So for example, if there's a tumor in this segment, the intestine will try to overcome that obstruction. It will strong contraction. And that will push the tumor into a next segment of the bowel, causing telescoping or intussusception. It can be associated with anything. Okay? But it is not the sole cause of intussusception. Tumors can cause intussusception. So intussusception is another example of intestinal obstruction, mechanical. Then adhesions, a commonest cause of intestinal obstruction, adhesions. Anyone who has undergone abdominal surgeries carries the risk of developing intestinal obstruction. Anyone, okay, because you interfere with the normal anatomy and it could traumatize them, and the body's response is inflammation and fibrosis. So it can adhesion formation like this, causing intestinal obstruction. It can cause complete obstruction, yes. It can be partial or complete, depending, yes. Then, yes, any mass lesion, right, now, can cause obstruction. So it can be a tumor, it can be a fecal mass, anything, some foreign body, right? Rarely gallstones can cause obstruction. And then strictures like this can be benign strictures or malignant strictures can cause obstruction. So all these are common causes of mechanical or dynamic obstruction. And all these patients, their peristalsis is initially normal. They will try to overcome, which causes colicky pain. But, okay, I'll come to that. So pathophysiology of mechanism and signs and symptoms of intestinal obstruction. So when there's an obstruction, what happens? Always there's proximal dilatation. And there's collection of ingested fluid. Whatever you ingest will be in your proximal part. And that causes abdominal distension. So in intestinal obstruction, one feature is abdominal distension. The reason is this, causes proximal dilatation. And this is contributed further by this. And this, when there's stretching of the intestinal wall, there's edema of the wall, it will interfere with your venous drainage, causes edema of the wall, and that causes leaking of fluid out of the intestinal wall into the lumen of the bowel. Okay, so you lose fluid because of the edema. So that will also get accumulated in the proximal part, contribute to the distension of the abdomen. These are all explanation for the physical signs. Then, when there's obstruction, the distal bowel will collapse. There's nothing coming there. So there's collapsing of the distal bowel. So if there's jejunal obstruction, rest of the bowel will collapse. Okay, so there's nothing there. So the patient will not pass any gas or anything beyond that point. So there's no flatulence. Okay. And because of the buildup of material, fluid and all the ingested content proximally, it will cause vomiting. And muscles will contract intensely now to overcome the obstruction, which gives rise to your colicky pain, which is partly ischemic. At some point, so if you examine this patient at this stage, for bowel sounds, your bowel sounds will be increased. Patient's bowel sound will be increased. So increased bowel sound is a feature of intestinal obstruction. However, after a while, the bowel sound will disappear, and that is not a good sign. Because that indicates now the muscle is exhausted, ischemic, and become paralytic. Okay, so that indicates paralytic ileus or paralytic bowel. Okay, so it become a adynamic condition now. A dynamic obstruction become an adynamic thing now. Okay. If there are vascular compromise, depending on the cause, like volvulus, obstructed hernia. Again, so initially you can get the colicky pain. If there's vascular obstruction, the ischemia can be continuous, which causes continuous pain. So in a first, the patient with intestinal obstruction will come and tell you it's a colicky pain. After a while, it becomes continuous. That is continuous ischemia. Now that is not a good sign, right? So he's now developing bowel ischemia, so that because of that you get continuous pain, and after a while, patient might say, oh, I'm all right now, right? Because there's no more pain, it's all necrotic, and they have no bowel sound at that stage. Okay, so those are some physical signs and clinical features of intestinal obstruction. Okay. Now, location of the obstruction can be identified using radiographs. Right? Some of the anatomical features might help you to some extent, not always. Right? Classically, if there's obstruction in the small bowel, distal to the small bowel, it will cause distension of the small bowel, dilatation. And characteristically, small bowel is in the central abdomen region. So you will see distended in an X-ray. There's distended bowel loops in the central abdomen. And because the small intestine have this feature, the plicae circularis, the circular mucosal folds, right around the circumference. Right? You will see these lines, the white lines. These are the plicae circularis, and they goes right around. So, and you will see the entire width, these lines appearing. Radiologically, these lines are called valvulae conniventis. That is the radiologically, these lines are called valvulae conniventis, and the valvulae conniventis are due to the plicae circularis distal. Okay. So if you see this transverse line from one end to the other end, right across the width of the intestine, that is the small intestine. Okay. Whereas in the large, if the large intestine is obstructed, so the large intestine will distend proximally, there these lines are not continuous, you can see. They appear close to the wall because this appearance is due to plicae semilunaris. They don't run, the mucosal folds within the colon, they don't run right across the loop, the circumference. They only appear partly. So therefore, they will not run the entire width. And colonic, usually they are wider than more than about 60 millimeters, more than 60 millimeters in a standard X-ray. And usually colon appears in the periphery, ascending, transverse, and descending. Usually, however, sigmoid colon obstruction, which is the commonest obstruction, commonly obstructed part of the colon, sigmoid. When it is obstructed, it is in the midline because it has a loop down in the pelvic cavity, but when it's obstructed, it comes right onto the abdominal wall like that. But it has the width of that the bowel is much bigger than the small intestine. Okay, right. So these are general features. So small intestine, they generally appears in the midline. They have valvular conniventis. Large intestine generally appear on the periphery. They don't have these lines running across the entire width. Few things. Okay. So these are few anatomical. So you might get diagrams like this in the exam, okay, and to identify. The other common feature of intestinal obstruction is the multiple fluid levels, and you know the reason why the fluid appears due to edema and congestion, okay, fluid leak out into the abdomen. So there's a lot of fluid within the intestinal loop, so that will appear as multiple air fluid levels. So in an erect X-ray, if you see multiple air fluid levels in a patient who comes with colicky abdominal pain, that would indicate intestinal obstruction. And this is a good article if you want to study more details about radiology of intestinal obstruction. Okay, so that's about intestinal obstruction. Moving on to the blood supply. Again, I'm not going to do this, so you can study the blood supply. Okay. So it is the studying of superior mesenteric artery and its branches. I hope you can do that. Right. Liver. Development of the liver, again, you don't need to know any details. If you know, the liver developed from the foregut, from the hepatobiliary diverticulum or hepatic diverticulum. That's enough. Location you know, please study the surface anatomy. Surfaces of the liver. So there are two main surfaces to the liver, diaphragmatic surface and the visceral surface. So the liver which is in contact with the diaphragm is diaphragmatic surface. So it has posterior part here, superior part and anterior part. So that is diaphragmatic surface. And the visceral surface is the bottom one, inferiorly, which is in contact with the visceral organs. That's a visceral surface. The posterior surface of the liver in relation to diaphragm, you can see it is in direct contact with the diaphragm because the peritoneum reflects from the abdominal wall onto the liver in this posterior aspect. So peritoneum comes from the posterior abdominal wall, reflect there on from here. So therefore this posterior part of the liver is directly in contact with the diaphragm. And this is where you get the inferior vena cava. Going. Okay? There. And in relation to peritoneal reflections, so this is the posterior, anterior view, that's the superior. What is this? Yeah? What is no, that is anterior. What is the peritoneal fold which coming from anterior surface of the liver to the anterior abdominal wall? Falciform ligament. So that is anterior. So we have this liver is covered by the peritoneum and there's a reflection of peritoneum onto the anterior abdominal wall. That's falciform ligament. Okay. And this the two sleeves of the falciform ligament continues backwards. I'll use the next diagram. So that is anterior here, falciform ligament. This is the posterior view. So this is that area I called, which is part of the liver which is directly in contact with the diaphragm. And all these are the reflected peritoneum. Right? Now they are again named. Right? So this big area here. Now these two peritoneal folds are called the coronary ligaments. These two. So the two coronary ligaments are the peritoneum reflected from the diaphragm onto the liver. So there's an anterior sleeve and a posterior sleeve. These are called coronary ligaments. And you can see the coronary ligaments. This is the left side. This is right side. And the two sleeves comes close together on left and right, forming the right triangular ligament on right side and left triangular ligament on the left side. So the two sleeves of peritoneum of the coronary ligament comes close together at the two ends, forming the two triangular ligaments. Okay. So that is the porta hepatis in the inferior aspect of the liver. So what is this then? That's a This is the lesser omentum. So this is connected to the lesser curvature of the stomach. So lesser omentum is actually goes from the lesser curvature of the stomach to the porta hepatis, like that. Right? They are all continuous. You can see all these peritoneal folds are continuous. Okay. So that's your lesser omentum. It is inside the groove here, deep. So then liver has left lobe and right lobe. Anatomically, the left and the right lobes are divided by using the attachment of the falciform ligament. So if you draw a line along the falciform ligament there, here that's a falciform ligament. So that is your left lobe, anatomical left port, and on the right side is your anatomical right lobe. But functionally, and that is based on their blood supply, the functional division of the left lobe and right lobe are different, and that is that the functional division is divided in this line, a line connecting the inferior vena cava and the gallbladder fossa. If you draw a line there, you can see the quadrate lobe and the caudate lobe, they are originally in the right anatomical lobe, but they go into the left functional lobe. So the left functional lobe include the left anatomical lobe plus caudate and quadrate, basically. That is based on the blood supply. Yes. Yes.
That picture doesn't make sense.
Yeah, so this is right lobe. This is left lobe. This is not pure inferior surface. I think it's an oblique view from posterior inferior. Because this is posterior, this one, and this is more anterior. Okay, looking from behind, this way. Okay, but it doesn't matter. What you need to study is, this is your right lobe. Okay, this is your left lobe. So your caudate and quadrate lobes are functionally in your left lobe. Okay, right. And also the middle hepatic vein. There are 3 hepatic veins draining the liver. Okay, there are 3 hepatic veins draining the liver. Right hepatic vein, left hepatic vein, and the middle hepatic vein. The middle hepatic veins usually occupy that line of division of left functional and right functional lobes. So middle hepatic veins along that. So that is what the surgeons used. We do a lobectomy. Okay, middle hepatic veins. Have you done the histology of the liver? Yes or no? Okay. All right. So I'll skip that one. Right. Coming to the portal system. Right. So the portal venous system. So that's the portal vein which is coming to the liver. The two main tributaries of the portal vein are the superior mesenteric vein, which drain in the midgut, and the inferior mesenteric vein, which drains your hindgut. Right? And this is connected by the veins draining the foregut structures, which include your splenic vein, then your left gastric, right gastric, those veins. Okay? So you have the superior mesenteric vein joins by the splenic vein to form the portal vein. The inferior mesenteric vein usually drains directly into the splenic vein before it joins the superior mesenteric vein. Okay? And most of the foregut structures, other than draining into the splenic circulation, they drain like left gastric vein, they can drain directly into the portal vein. Foregut structures. Okay? Right. And usually you can name the veins according to the arteries. Right? If there's a right colic artery, there should be right colic vein. Left colic artery, there should be left colic vein. You can use. Okay? I have not gone into the details. You can study that. Right. Portal hypertension. So when there's increased pressure in the portal system, we call it portal hypertension. So portal hypertension anatomically can be categorized into three: pre-hepatic, hepatic, and post-hepatic. Now in the venous system, blood drains this way, coming to the liver, from the liver goes to the heart. So this area is where you get the portal vein, your superior mesenteric vein, your splenic vein, inferior mesenteric vein. They are before the liver because blood comes that way. So it's called pre-hepatic, right? So obstructions can occur in the pre-hepatic circulation, leading to hypertension in the pre-hepatic part of the portal circulation before coming to the liver. Second category of disease of portal hypertension occurs within the liver, called the hepatic type of portal hypertension. So the pathology is within the liver. Any liver disease, chronic liver disease can cause that. Third one is more proximally between the liver and the heart. It's called post-hepatic, right? Post-hepatic obstruction. Now these are the causes. Pre-hepatic, any pathology in the portal, the main portal circulation, thrombosis of the portal veins, thrombosis of the superior mesenteric vein, inferior mesenteric vein, portal venous atresia, or compression of a portal vein due to a tumor. Right? Any gastrointestinal tumors, pancreatic tumors, colonic tumors can compress the portal vein or superior mesenteric vein. That can cause development of hypertension beyond that point. Okay? Then hepatic causes are any disease of the liver, like cirrhosis is the commonest. Causes fibrosis, and fibrosis causes narrowing of the vasculation there. And then secondary malignancies, hepatitis, all these can cause. So liver diseases. Then the post-hepatic ones are rare, except for congestive cardiac failure. So when there's cardiac failure, there's problem in the heart, so there's pressure in the inferior vena cava. So congestive cardiac failure can cause a post-hepatic type of portal hypertension. That is why in congestive cardiac failure you studied last month, I think, they can develop congestion of the liver, hepatomegaly, they can develop ascites, those things. So that's a post-hepatic cause. Okay? Right. So those are causes. What is the outcome? So these are things causes give rise to the physical signs. So when there's pressure in the venous system, it causes venous congestion. So it affects the venous return, right? And it affects that at the capillary level. It causes fluid leakage into the extracellular space. So when the fluid leaks in the portal circulation, they can leak into the extracellular space of the organs. In liver, it can cause hepatomegaly. It can cause the spleen. It can cause splenomegaly, as well as it can cause intestinal edema. Right? So that is collection of fluid in the extracellular space. Not only that, it opens up portocaval and communications. So there are communication between the portal system and the systemic system. Usually most of these communications are closed. Not much blood passes through those. But when there's obstruction, they opens up. So there are two things. It can cause venous congestion leading to ascites and organomegalies, and then opens up portocaval communication and giving rise to conditions like varices, hemorrhoids, and caput medusae. Right? So I'll go through this now. So when this portosystemic anastomosis opens up, before that, so these are the locations of the portosystemic anastomosis. That is, the portal system and the systemic veins are linked. The common locations are around the umbilicus. So around the umbilicus, the intestinal veins and the skin anterior abdominal veins are anastomosed. The portal system veins are the paraumbilical veins. They are called paraumbilical veins, and most of these veins drains along the ligamentum teres towards the liver. And the systemic veins are the superficial and inferior and superior epigastric veins draining into the inferior vena cava below and superior vena cava above. So there's a connection between the caval and portal system. So this is portal and this is caval systemic. Then around the anal canal you have the superior rectal vein draining the anal canal into the inferior mesenteric vein, into the portal vein. And below, anal canal is drained by inferior and middle rectal veins. They drain into the inferior vena cava, internal iliac vein and inferior vena cava. So anal canal is a location where you see the portal and systemic anastomosis. Then lower esophagus is a very important site where the left gastric vein, which drains into the portal system, and esophageal branches of the esophagus system drains into the superior vena cava. There's a connection in the lower esophagus. And there's another one in the posterior abdominal vein. You get in the retroperitoneal all these colic veins, like the middle colic vein, left colic vein, right colic veins. Their branches can connect, communicate with the body wall veins or the lumbar or retroperitoneal veins, which drain into the inferior vena cava. So this one drains into the portal, this one goes to the inferior. So there are connections in these locations. Now this is what happens there. So if you look at this cross section of the bowel or GIT, this is the mucosa, submucosa, and the muscularis. In the submucosa, you get the most of the blood vessels, capillaries. So this is those capillary plexus within the submucosa. They are normal. And these capillary plexus are connected to the systemic circulation, drained by both systemic this way and drained by the portal circulation. That is normal. Okay? Now, when there's a problem like this, say, assume that patient has cirrhosis. What happens? There's obstruction to the portal vein. It will cause increased pressure in the portal circulation. Now, blood usually drains this way into the portal system. Because of the pressure, now blood passes through the portal system into these small capillaries within the submucosa. In the anal canal or esophagus or whatever, there, around the umbilicus, right? So they go, more blood pass through these small channels now. Is that clear? And then drain back into the systemic circulation through these veins. Okay? This is what happens. They become elongated, tortuous, and distended veins. And they project into the lumen. And they will be covered by a thin layer of epithelium.